Hello, everyone.
Yeah, she said they couldn't do anything.
Good evening, everyone. Can we get seated? We're just about to start. So good evening and welcome to the latest in our inaugural lecture series. It's so pleasing to see so many people here, friends and family of the speaker, students, and members of staff, and a baby, actually. And welcome also to all those online. We're really looking forward to a very exciting talk today titled Health, Humanity, Hope, and the Story So Far by Professor Joanna Raven, who is also the Deputy Head of Department International Public Health. This is an opportunity, this lecture series is an opportunity for staff to showcase their research, their achievements, their journey so far, and where they intend to take their research. I've known Joanna for many years. She's trained as a midwife. I don't want to go into her short CV because I'm sure she has a fantastic story to tell us. She's going to speak for 45 minutes, after which we have some question and answers, and then we hope to wrap up after 1 hour, 30 minutes. We'll also have some refreshments, outside, once we finish. And it's a good time to interact, with the whole audience, including members of our family here. So without much ado, I'd like to welcome Joanna to start her talk. Big round of applause, please.
Thank you, Charles. And thank you ever so much to all of you who are attending today, you and people online as well. Can you hear me okay?
Yes.
Great. So I'm a health systems researcher and I'm a professor in health systems. And most days I wake up and I pinch myself and think, how on earth did I get to this? So with all the best stories, you start at the beginning, don't you? And you see what's happened over the course of my life to shape what I do now. So, I was born and delivered by my grandmother, actually, and brought up on a small family farm in rural Herefordshire, which is right on the border to Wales. And we have generations and generations of farming families. So they were all in the middle of Wales, and they came down from the hills into the flatter areas of northwest Herefordshire. I'm the youngest of 4 children. I'm second from the left. Oh no, second from the right, sorry. Second from the left is Minstrel, the donkey. Just to make it very clear, I'm this one here. Not this one here. Anyway, so as I'm the youngest of a family of 4, and those of us who are youngest of families know the injustices of the world that we experience. Lots of injustices. I was locked up, tied up. We were the Red Fox gang, this lot. We were the Red Fox gang, and I was the cook of the Red Fox gang. So as everyone else went on lots of adventures, spying on people, exploring areas, I was left at home, at camp, to do the cooking. Hence why I hate cooking. But really, this was an amazing childhood. We had such freedom. We cycled everywhere, we ran everywhere, we swam in the rivers, we terrorized the local community. We helped with herding the sheep around the farm because the sheepdog was useless. We picked strawberries and raspberries, but it was a really lovely childhood. But we were heavily influenced by this woman who's my Auntie Flo, who was also from that area, and she left and trained as a nurse, a midwife, and a health visitor. Now, this is in the 1950s, when it was quite rare for that to happen. Usually, you were expected to stay in Herefordshire, near the farm, and marry a farmer. But she had other ideas. And she went to work in lots of different settings, including Yemen, Iraq, and in Vietnam for Save the Children during the American War. And as part of all her travels, she used to send back scrapbooks. So things that she'd find, put them into a scrapbook and send them home to us. And these are some of the pictures that she drew of the experiences and what she saw in Vietnam. So rice harvesting, a woman cycling in traditional dress, and refugee camps as well. So she did that, and what it did was it opened up another world than Staunton-on-Arrow and the farm that we knew so well. It opened up that world and that interest in other places and adventure. And for me, it really inspired me to become a nurse and a midwife. So that's what I did. Sorry, this is going to be a funny photos of funny haircuts. So anyway, here I am with yet another funny haircut. But so I went off and trained as a nurse in London at Guy's Hospital. And I remember when I was interviewed for this training post, they were very worried about me coming from a rural farm to the capital city. And I remember saying to them, "Have you ever been to Herefordshire?" And they're like, I said, "If you had, you would know why I wanted to leave." So fortunately that I did get the place. And I went on and trained as a nurse and a midwife, and well, as a nurse then. And I worked in London, in southeast London, in a casualty of a big hospital there. And again, lots of different experiences, but lots of knife crime, gun crime, drugs, Millwall Football Club, trying to tackle them when they're throwing everything at you. Also, a woman who seemed very nice from the outside, and I was trying to help her with something, and she pulled out of her bag a sock with a snooker ball and whacked me over the head with it. So anyway, I survived. But I thought, right, I want to save all my money and to go travelling again. So that's what I did. I travelled through South Asia. I worked in Nepal teaching English for a little bit, and then ended up in Australia, where I travelled around Australia working as a nurse. I left Australia. Actually, I was banned from Australia, but that's another story. Just for 2 years. I have been back under a different name, but anyway. I ended up in went to South Africa and to Lesotho, where my sister and Kevin, her husband, were living and working. So these were my first experiences of really different communities, different cultures, and the inequities in this world, really. And it really sort of touched me a lot. So I returned to the UK, and I fell in love. I got married and widowed and qualified as a midwife, all in 4 months. So this was a time for me to really focus on being a midwife, of really, trying to get my confidence and competence and my skills, and really strengthening myself for the next adventure. And, over time, doors began to open again for me, and I started to live again. And so my strength was back, and I was ready for an adventure. So with a pelvis under one arm and a tiny tears doll under the other arm, I went off, and this is where I ended up. Any ideas where this might be?
Maldives?
The Maldives, yes it is. Yes, it is. It's the Maldives. So usually known for its holiday destination and honeymoon resort. But Maldives is at this, the southwest tip of India. It's a long string of islands, over 1,000 islands, 200 of them inhabited, 100 plus tourist islands, so they're separate. A population at that time, so this was in the late 1990s, population was about 300,000, so quite a small population, but they were scattered through all of these different islands. And this is the capital island, Male, very, very densely populated. And then within the other string of islands, there's 4 regional hospitals and lots of different health facilities. What was I doing there? I wasn't on holiday. I was actually a midwife trainer for the Faculty of Health Sciences, which is a part of the government there. And I was working through Voluntary Services Overseas, VSO. And my job there was to train midwives and train on reproductive health. And I remember the first meeting of when I met the head of the faculty. And she said to me, "Oh, I'm so glad you're here, Jo. All the midwife trainers have gone to Australia to do master's programs." I was like, "Oh, when are they coming back?" Because you usually sort of pair with people to work with them. "When are they coming back?" "Oh, well, 3 years." But to be honest, Jo, they often don't come back. It was like, oh, great. So then I said, all that went through my head was that actually, I am so pleased I did a 2-week training course on how to be a teacher in Birmingham before I came here. Because that is all the training, teaching experience I had. But, I really grasped this opportunity of teaching and training. And I tried to make things fun. So I generated lots of different ways of trying to teach and lots of different games. So, you've got to bear in mind that Maldives, there wasn't a lot to do in the evenings there. So I was resorted to making maternal mortality Monopoly. Snakes and family planning, snakes and ladders. And I made my own sort of resources like cardboard pelvises and knitted placentas. And I think maybe my lasting legacy from Maldives is that there's a whole lot of health workers dotted around the islands who can knit. And not only knit placentas, which is it's a very useful skill in a tropical climate like Maldives. Well done, Jo. Anyway, I did lots of teaching, lots of training in the capital, but also on the islands. And I probably went to most islands, inhabited islands, over the period of time I was there. And one of the key challenges that people faced, and particularly women in labour and in pregnancy, was travel, transport, accessing skilled healthcare. So a lot of those inhabited islands, they didn't have jetties or harbours. So when you arrived at an island in a bigger boat, you'd have to wave at the shore, and hopefully they'd send a little rowing boat out for you, and you'd get in it and go into the island. Now this is all okay in the good weather and in daylight, but night time and during storms, and if you're pregnant and if you're in labour, this is really, really challenging. So Maldives had lots of challenges there. There was a lot of home deliveries, a lot of traditional practices, large families, very little family planning, abortion was illegal there. So lots of different sort of cultural and societal sort of challenges, really. And I remember one, there's lots of stories from my work there, but one in particular really focuses in my head. And it's about Aminat, who was on one of these small islands, was in labour, and she was being looked after by a community level health worker, and really she was in labour for too long. And by the time they thought, actually, we need to refer her to the regional hospital, it was getting late in the day. And then by that time, they had to find the money to pay for the boat transport to the referral hospital. And this was extremely expensive, these boat journeys. So, and then by the time they got that money, the boat captain, it was dark, and the boat captain said, I can't go on the boat. It's too dangerous because of the coral reefs. And unfortunately, it was cloudy as well, so they couldn't steer by the stars, which they often do. But they decided not to go. It was too dangerous. So they went, the first light of that day, at dawn, they left for the referral hospital. And I was at the referral hospital, the regional hospital. And I remember when she got off the boat, she was petrified, she was exhausted, she looked really ill. Unfortunately, the baby died. She survived, and we looked after her for a while, and then she went home. Now, this story really worried me on lots of different fronts. And the first one was about the health worker not recognising soon enough that she needed to be referred, knowing the geography of the place. And the other one was, why isn't there an emergency fund for transport for people? So I went to the atoll chief, and probably 100 coconuts later, we agreed to put in place an emergency fund for transport for that atoll and for all of the different islands within that atoll. Then I went to the Minister of Health, bearing in mind this is a small country, so I could just go into I knew him. So I said, right, we need to set up continuous professional development for health workers who are on those islands. And we need to rotate them round so that they do end up at the hospital where they can rejuvenate their skills and their confidence in managing childbirth and emergencies. And that worked as well. Then a couple of years later, I went back to the island where Aminat lived, and she was there with her baby, very happy. This time, she decided to go and stay at the regional hospital island so that she didn't have to go through that ordeal again. So Maldives experiences taught me several things, important things. Firstly, that clinical skills and knowledge are really critical, important, but they're not enough. Understanding the context, the society, the behaviours, the values, the traditional practices is essential to ensure that we deliver health services that people want and can access. And importantly, that the system that supports service delivery is really there and strong, so that the drugs and equipment are there, are working, people know how to use them properly. The health workers are there, they're skilled, they're knowledgeable, they're confident, and importantly, they're supported and valued. The information to make decisions about healthcare, what to resource, what to prioritise is there. And the last one is about the governance structures are there, at the community level, at the facility level, at the health, at the central level, the Ministry of Health. All those governance structures are there, they're strong, they're in touch with each other, and they're in touch with the reality of childbirth, of pregnancy, of delivery in these sort of settings. So, after 4 years of working there, I'd kind of worked myself out of a job. I trained lots of midwives. I trained anybody who wanted to be a midwife, or, so people in the police force and the army. I was brought in to do sort of training with them. And importantly, I trained the trainers as well. So there were people there to take on these roles of training as well. So where did I go then? Well, recognize this? Actually, I had come here before. While I was out in the Maldives, I'd come back for 3 months to do the certificate in community health, where Sally supervised my project. And I thought, this is a good place to be. I think I'd like to come back there. So I did. I came back to do a master's in community health, with the real idea of going back abroad to work on maternal health programs, but this time be paid. But things had other ideas. I was bitten by the research bug. And as part of the master's, I did a study. I went to China and I did this research study that looked at the postnatal practices, the traditional practices in the postnatal period, which are a kind of a group of practices that are kind of quite unusual, but trying to explore that. And I really loved this. I loved this idea of exploring and uncovering stuff, of really trying to work out things and talking to people about their experiences. And I really, really enjoyed that. And I also had my first paper published. Here it is here. And I'm still so proud of this paper because it was the first paper that I'd ever written. And it was like, I couldn't quite believe that people would want to read something I'd written or thought, really. But anyway, so started my academic career at the age of 38, and not planned, not aimed for, kind of just happened, really. I was offered a research assistant job, and then a PhD alongside that, and then more research jobs. And I've led maternal health research projects and health systems projects since then. So these early days, these experiences, really shape what I do now. Let's have a slurp of water. It's a bit warm in here, isn't it? Okay, so firstly, introduce the people I work with. These are a lovely group of people. So the Health Systems Workforce Strengthening Group, Clara, Cleo, Eunice, Ewan, India, Karen, Louise, and Wessam. And then so I lead that research group. I'm also the co-director for the Institute for Resilient Health Systems with Gillian, Jacinta, Kerry, Marisa, Miriam, Moses, Tita, and others as well. So I work with these people, but I also work with lots of people across the school and with lots of partners across the world, and I'll talk about a few of those in a moment. And I want to, I work on two broad areas of research, really, now. And the first one is management strengthening. And I want to talk about 3 projects here. There are others, as these are just examples of my work in this area. But what they do is they build on each other. Over the course of time, they've built on each other and they're interlinked. So the first one is about Perform, which is about strengthening decentralized management to improve health workforce performance. And this was in Ghana, Tanzania, and Uganda. It was from I can't remember when it was.
2011.
2011. See, Tim led it, so he's got those dates ingrained in his head. Anyway, it was funded by the European European Framework 7. But the premise was that, yes, we need more health workers. I think there's a song in that, isn't there? Yes, we need more bananas. Yes, we need more health workers. Everywhere in the world, really. In most places in the world, anyway. But we also need to really support the optimal performance of the existing workforce. So what do we do to support the existing workers to perform as well as they possibly can in these settings? And what we did was introduced a management strengthening intervention where district managers really identified the problems that they wanted to address in terms of workforce performance and service delivery, and then worked together to devise ways of addressing those problems, implemented them over a period of time, and really then observed, monitored, and reflected on what worked, what didn't work, and why. So it's an action research approach that we took here. And this worked. It worked really well on two levels. Firstly, on the performance of the health workforce. So there was less absenteeism, better quality of care, better sort of teamwork amongst the health workers. And this was all reflected in service delivery. So people were coming to the facilities for healthcare, and they were being able to provide those services as well. And then the second level it worked on was in terms of the management. This supported managers to own problems. They were used to people saying, this is the problem you need to address. They were saying, oh, this is what I want to address. This is, there's so much knowledge within district management teams, this tacit knowledge of what the problems are and what to do with them. It's a way of facilitating them to come together and allowing that space for them to be able to come up with those solutions and support them to implement those solutions. And they did. And so this helped with teamwork across the districts. But we also found that actually, this was in 3 districts in 3 countries. What do we do with this now? How do we make sure that this reaches other people and scales up, scaling this up? So we moved on to, guess what the next project was called? Any ideas what this project would be called? Perform to scale. Yeah. So this was scaling up this management strengthening intervention in different countries. Tim led this too, and I was the research director there. And we generated really important lessons for, often we pilot an intervention. We always sort of pilot it in a research project. How do you get it to be institutionalized within a country, within policy and practice? How do you do that? And this research was about that. And what we did here, we had different lessons that emerged from that was arguing the value of the intervention. Sounds simple, sounds obvious, but actually what you have to do is be able to gather the data that you really need to persuade people to take this up, okay? It's building a coalition of champions and structures for scale up. It's about looking for windows of opportunity, so aligning these interventions with what's happening in the policy arena at that time, what's important for decision makers, and trying to find that niche and weave your way into it. Realizing that often interventions, when they've been piloted, sometimes when you scale up, you need to make trade-offs with them. and being clear what those trade-offs are and what that means for the ultimate sort of impact of that intervention. And then all of this is about thinking and working politically. And this is something that I learned when I was in the Maldives, when I was trying to persuade the Minister of Health about that continuous professional development, and also the atoll chief. I worked politically to make those arguments for those interventions. And then the next research area, research project within the management strengthening, was this one about retaining health workers in hard-to-reach districts in Ghana. So we used a similar action research approach, and this was funded by the Global Health Workforce Programme. And I co-led this with Patricia Akpiongo of the School of Public Health in the University of Ghana. And we were asked by the Ghana Health Services to go and work in these really difficult, hard-to-reach districts, and they were hard to reach. I spent hours getting there. But these places had real shortages of health workers. Health workers would be deployed to go and work in those districts, take one look at it, and go back, you know? Or they'd hear that, oh no, I've got to go to Afram Plains North, isn't it? Yeah, Afram Plains North. And they look at it and they say, I'm not going there. And they'd somehow sort out a transfer. So pretty challenging environment. So some facilities only had one health worker. There were very few midwives there. So people weren't getting services, healthcare services, or relying very much on families or on traditional healers, or drugstores, or travelling long distances at quite a lot of expense and time to receive any healthcare. So we used, again, this action research approach, so where we brought district managers, facility managers, community members, health workers together. We got them together, we collected data on the situation, we analysed that data, we looked at the problem of retention and tried to work out what were the root causes of retention, and then try to find sort of solutions. So the solution bit was really tricky, because at the start they'd say things like, well actually the Ghana Health Service should do this, and the government of Ghana should build a road. You know, all of these things, which are right, they should. And I'd say to them, yes, you're right, absolutely right. They should do all of these things for this environment. It's right. But they haven't. And there's no real signs that they're going to do it for a little bit anyway. So what can we do today? What can we do today and help your health workers in these areas to provide services that they want to do? So that's what they did. And they started to think of different ideas to do this. Things like renovating the accommodation for health workers. Something as simple as putting a lock on the door so that women felt safe in that facility, in that accommodation. Putting a toilet in to the accommodation so that the women didn't have to go into the jungle to go to the loo, where they were at risk of assault. So, and other things much more sort of complicated, well, not more complicated, but training on quality of care, looking at the revenue generation within the facility, lots of different things, a package of interventions. And this really, again, it worked. You know, it helped improve satisfaction, and there are reports of willingness to stay in those districts. We still need to look at the data long term about retention. It also helped with bringing people together. They started to realise that it's all of our responsibilities to sort this problem out. You know, the community health worker, the community members, the health workers themselves, the managers, the district managers, we got the regional people involved, we got the national people involved. So it meant that this is a problem and we all need to solve this, really, to help support health workers. And it really meant that a little support can go a long way to improve workforce retention. And this approach has been shared widely in Ghana. It's been taken up by other districts in Ghana, and we're developing a case study for the new WHO guidelines on health workforce retention in remote and rural areas. Okay, the next area of work that I really focus on is health systems in conflict-affected and shock-prone settings. So we all know that 2 billion people, that's a quarter of the global population, live in these settings. So this is a huge issue, really. And there are 39 fragile and conflict-affected settings, according to the World Bank. So I want to talk about 3 projects that really focus on this. And the first one is Rebuild, the Rebuild Consortium, which was from 2011 to 2019, really focused on health systems in post-conflict settings. And it's again led by Tim and Barbara McPake in Edinburgh. And I was a researcher on this project. And at this time in 2011, we knew that the health indicators are the worst in these sort of settings, and the health systems are probably the weakest. But there was very little research done in this area of post-conflict and conflict-affected settings. So that's why we did this work, and it was a huge amount. It was a huge program of work. I had a small part in this, but I led a study on community health workers and their role in these sort of settings. I led a research project on health workers' experiences of the Ebola epidemic in Sierra Leone, and I led a project on contracting in Cambodia, but please do not ask me questions on contracting. It's not my forte. But really, it was a huge body of work, very well cited across the world. And 3 sort of areas came out, really, that understanding the impact of conflict and crisis on the sort of intersecting inequalities that households and families and communities face is really important when you develop policies. So this study, all Rebuild, focused a lot on policy development, sort of national level stuff. Health workers demonstrate amazing resilience during the crisis. But what do you do after the crisis is over, the conflict? How do you support them through that? How do you get them to navigate this? So the mental health support, financial support, because they're often very poor areas now because of the conflict. And then the post-conflict period is really shaped by an influx of multiple players. So multiple organizations come into a country or a setting after a conflict and want to deliver healthcare services and other services as well. But actually trying to enable where possible and where appropriate, the national and local health system to take the lead and become legitimate again. So that strengthening those sort of levels of governance is really important for long-term sustainability, because soon those NGOs will leave, and what will happen to the health system then? So a focus on the health system at that point is important. So moving on to Rebuild for Resilience. See, there's a pattern in our acronyms. So this one is really about, it's another Department for International Development Research Programme Consortium. And it really, and I lead this one alongside Sophie Witter. And this one really focuses on the capacity, the resilience capacities of the health system. So what capacities does the health system have to enable a response to different kinds of shocks like conflict, but also widening it to pandemics, earthquakes, and other kinds of shocks as well, financial shocks, political instability. So we move from post-conflict to actual, while in crisis and while experiencing the shock. We also broaden to the whole health system, so trying to look at all of the capacities of the health system to respond. And we also focused on the district, the local levels, rather than the national level. And this is because there's quite some research on resilient health systems, of conceptualizing that, of understanding the challenges of health systems in these sort of settings, and also to some extent measuring the metrics of it. But what was missing was really looking at what on earth do you do? How do you support the resilience of health systems? How do you support those capacities and strengthen those capacities so that when shocks happen, the health system can work and operate and continue to provide services? So this was what Rebuild was and is. And it operates in lots of different countries across the world. And the main partners are in Nepal with Herd International, with Lebanon with AUB, Myanmar with the Burnett Institute, and Sierra Leone with the Institute for Development. And we're coming to the end of this programme of work, and we're really grappling or juggling with all of this data now and really trying to make sense of all of that coming together. And I just want to give you a couple of snapshots from that. Firstly, about these different resilience capacities. And the first one is creating learning spaces in local health systems. So here, it's about, I'll give you an example from Nepal here. So where decentralization of the health system came into Nepal suddenly, quite abruptly. And so suddenly the local government were responsible for governing the health system in that local area. So it was kind of like Sushil, our colleague in Herd, always says, it's like overnight they had to take on this responsibility. They had no training, they didn't know what they were doing, they didn't know how to link up with different parts of the health system. It was really tricky. So what we did there, the Herd team worked with the municipality, so the local government there, to try and make this a learning space, so that they would use the data that they'd got, understand that data, collect more data if needed, and based on that, make decisions about service delivery, how to prioritize, how to allocate resources. The second area is about mapping and supporting non-state actors and community actors. So often when a crisis or shock happens, it's the community that has to move in to support the health services. And really mapping that and supporting them to be able to do that and understand how they do that is critical. So a good example of this is from Myanmar. So when the military coup happened in, I think, 2020, there was a real non-engagement with the military government. So this was when those community actors, those NGOs, really took over health service delivery in those settings and how they did that. And thirdly, Actually, I won't go for the third one. What I will say is that if you're interested in Rebuild for Resilience, we've got a day of it on the 13th of May. So please do come to that. And the third research project I want to talk about is REACT, which is, it focuses specifically on the shock of climate crisis. And we're really looking at how does the health workforce respond to the health impacts of the climate crisis. The health workers are the ones that kind of have to take all of this, you know. What are they going to do about these health impacts of climate crisis? So again, we're using this sort of action research approach to do this. And we're in year 1 or year 2, and we're starting to collect data on a situation analysis of the different districts, 2 different districts in each, in Nepal and in Zimbabwe. And they all experience different climate crises sort of things, really. And then underpinning these research areas are 2 cross-cutting themes. And the first one is capacity strengthening. So, and this is a theme that has cut across really all my working life, I'd say, starting in the Maldives, where I did all that training and supporting the capacity of local trainers as well. And I really believe that people should be given a chance. So thank you to Tim, to Rachel, to Sally, and to Paul Garner for really giving me that chance when I first came to LSTM back in 2004. You gave me the opportunities to work and to flourish, really, so it means a lot. So capacity strengthening is very much a key theme that runs through all my programs. You know, we really do need to do that. I feel very strongly about that. And making sure that we take the opportunities to learn from each other as we navigate the challenges of doing research in fragile settings. It's also reflected in the PhD students that I support, the master's students that I support, and the ones I've supported in the past who have gone on to do really great things. I also teach a lot. A couple of weeks ago, I ran a participatory action research session with the Institute for Resilient Health Systems in Sesha in Zimbabwe. I work with Wessam Mansour to deliver the module on organisation and management of health services, and with Jacinta to develop a short course on health systems resilience. And critical to all of this is partnership, underpinned by values. And I try my best to live LSTM values and also my own personal values too. So things like trust, showing respect, treating people with dignity, kindness, ethical practices, safeguarding practices, striving for quality, and ensuring voice for people. Really important to me. Navigating these in any setting is tricky, but really difficult in fragile and conflict settings. So it's really about looking out for each other. So critical when we are working in such turbulent times. When we started Rebuild back in 2020, we went straight into COVID-19. Then we had the Myanmar coup, military coup. We've had the Myanmar earthquake. We've had the political instability in Nepal, real riots and political instability in Sierra Leone, wars in Lebanon. And those are just some of the shocks that we've had during that programme of work. But I think it was because of our close, supportive and trusting partnerships that we managed to get through. Right, So what to the future? Oh no, that's my partnership one. Nice photos, smiling. It's future research. What next? Well, I really want to continue to work in these challenging settings. These ones that are fragile, conflict affected. We've got more fragility in more wars than since World War II. So I want to do work in these most difficult places with people who are the most marginalized and often most in need, like Democratic Republic of Congo, like Yemen, like Myanmar. These are really difficult places to work, but it's possible, and we've shown that it's possible. And some of the research areas that I want to focus on are things like, some of the responses that the health system's responses that we've observed and researched in rebuild have been quite short term. They're using existing resources in a different way. But what we really need to do is work out how do you get to transform the health system so that it's better able to sustain and to continue to maintain services when a new shock happens. So this transformation of the health systems, I want to look at that. I also want to look at I feel the underpinning sort of resilience capacities like learning and trust and inclusivity are really critical to resilient health systems, of health systems able to respond. I want to look at that. How do we operationalize those? How do we track those moving forward? How do the gendered power structures affect who participates in and who benefits from resilience responses? We need to unpack that more. And how can insights from fragile and shock-prone settings really inform resilience in other settings across the globe? Also, an area of real importance to me is about women and leadership in health systems in fragile settings. And I'm trying to move that work along with a potential PhD student who wants to work in sort of displaced camps for refugees and displaced people in Uganda, and look at that leadership area there. And then finally, there are different models of healthcare. What are the health workforce and health systems adaptations that you need to make to deliver those different models of care? So, for example, we're looking at the moment at sickle cell disease, and how do you move that to the primary and secondary levels? What does that mean for the health system and the health workforce? Similarly with integrated hypertension as well. But that's not all that I do. There's another side to me. So I went back to Northwest Herefordshire and I married my farmer. And this is where I live. So my husband is a farmer. He runs a cattle and sheep farm right on the border with Wales. And I think I help at times, maybe. But this is my happy place. It's so beautiful. It's so peaceful. I love the trees, the fields, the animals. The sky is so big. You go to the highest point of the farm and you can see maybe 8 counties. And it's my happy place, as I said, and it keeps me grounded. I think we've come round full circle now. And we all want the best possible health. And we all need access to healthcare, whoever we are and wherever we are in the world. And in the world of artificial intelligence, of conflict, of violence, of misinformation and disinformation, showing empathy and understanding is so critical. And I do have hope for the better world. And these are the people who are at my side. Thank you.
Thank you so much, Joe. I'm sure you were all captivated by that story. I mean, really, it came full circle. You could tell from when she went out to Maldives as a very young, inexperienced midwife, solving health system challenges, negotiating. I mean, I really love the coconuts. How it helped to change and put the system in place for transport. And then how she came to LSTM and got that research bug. What I really liked about LSTM when I first came was that master's students had the opportunity to actually go overseas and collect data and do their projects and end up publishing that work. That made us stand apart from other institutions. And you can see how a 3-month course went to a master's course to a PhD and a very well-defined research niche. Now, the bad news in this conversation, this exciting story we've had, is that we probably only have time for no more than two or three questions.
I went on too long.
But we will have up to 30 minutes, with refreshments outside, and then we can do lots more questions. So maybe we prioritize questions online. If Clara, any questions online?
Yeah, there is. Yeah, there's two.
Oh.
Okay, two quite different ones. Sorry. Okay, two quite different ones. So the first one. So thank you for the inspiring talk.
Oh.
That wasn't from me. That's from
Oh, right, okay. I thought that wouldn't be you.
Okay, so you've mentioned action research.
Yes.
Obviously. I was wondering how you would differentiate your action research, if at all, from implementation research. Are there additional components in the action research approach? I know that's a big question, but maybe just a quick.
I think action research is a part of implementation. Implementation research is the big umbrella, and action research is part of that. I think action research is very much about action and reflection. So when you go through a cycle of action research, you end up reflecting and learning at that point. So it's about learning about it as well, which I guess is implementation as well. But it is this action research cycle that we go through.
Okay, and then this question, which is a really nice question. So, thank you, Professor Joe, which we love calling Joe. My question is that if you had the opportunity to go back and make this journey again, what would you do differently, and what advice would you give your younger self?
Oh, golly. If only you can go back, really. I don't know whether I'd change a lot of stuff. I think all of the experiences have provided me with good things, I think. Even the sad things and the difficult things, there's always something there that makes you a better person, I think, in the end. So I don't know as I would change it. I think if I was talking to myself as a younger one, I'd think, forget being the youngest of 4 children. Get over that quickly and say, actually, I'm a person in my own right. I'm brilliant. I don't know. No. But that's for everybody, really.
Maybe we take one question from the room. Can you take us? Yes, please. The mic.
Shout it out,
I was
Charlotte.
going to say, yeah, I've got a loud
You've
voice.
got a loud voice. People online. Yeah, good point.
Joe, you are undoubtedly an expert in health systems resilience, but I also think you're somewhat of an expert in personal resilience. The fact that you have been exposed to all of these really challenging settings and you still want to go back, and you do it with a smile and such joy and sunshine. So what advice do you have to everyone else in where that resilience comes from?
I think my resilience comes from, I think it comes from hardship, I think, and that actually I've lived in sort of desperate situations, and I've learnt to come out of that, really. And I laugh a lot. I try to find things that are amusing to me. And I hope that's never offensive to anyone else, because it's never meant to be at all. But I try to find those sort of nuggets of something that is enjoyable or funny, or I think, oh gosh, I can't take anything too seriously. Because when you start doing that, I know with me, I find a slippery slope there. So that's what I do. I pull myself back from that and try to be strong and resilient in that way. And I hope, I forgot to say in the talk, that I hope that it really, you know, I love my work, and I hope that came through in the talk. And I feel very, very lucky and privileged to be part of it. Yeah.
Thank you so much, Jo. So we have drinks outside, and I probably will talk to her because I have one question. There's a huge gap in the story. What happened in Australia? It's a huge gap that we have to fill. So I think after one or two glasses, we'll get the details. But thank you all so much for attending. You know, it's been a huge audience online and in the room, and we look forward to the next talk in this series. So you're welcome to drinks. Thank you.